Hello, everyone, and welcome to our final session of Echo Asthma Bootcamp. Thank you all so much for joining us. My name is Ashley. I'm your facilitator. I'm joined by my coordinators, Rachel and Tabitha, and our wonderful hub team, Dr. Mandeep Jassal, Dr. Christian Hermansen, and Andrea Jensen, certified asthma educator. All right, today we are going to talk about managing injectable medications. Alrighty, so now we can get started with our lecture on managing injectable medications. This will be presented by Dr. Care.
So welcome to session 6 of the Echo Asthma program. Today we'll talk about managing injectable medications. My name is Dr. Sucharita Kher. I'm an assistant professor at Tufts University School of Medicine and an adult pulmonologist at the Tufts Medical Center Pulmonary Clinic. So we've reviewed this before, but there are 5 FDA-approved biologics for use as add-on treatments for severe asthma. This is for when patients' asthma is uncontrolled despite use of high-dose inhaled corticosteroids and another anti-inflammatory therapy such as a leukotriene antagonist. These drugs include omalizumab, mepolizumab, breslizumab, benralizumab, and dupilumab. We have the targets for each of these drugs listed here, as well as the age for administration. The one thing I'd like to highlight here is the dosing interval as well as the route of administration. And as we're having a shared decision-making conversation with the patient, it's important for us to realize that each of these can bring a different option to the patient. So omalizumab is a drug that's typically administered every 2 to 4 weeks. It often requires in-office administration, and because of the small but real risk of anaphylaxis, it requires an EpiPen for administration. It's important to note that during this COVID-19 pandemic, however, there have been some exceptions made that patients may be able to administer omalizumab at home if certain specific criteria are met. Mepolizumab, on the other hand, is administered every 4 weeks subcutaneously. And again, a self-injection option is available for ages 12 and above. Breslizumab is an IV therapy and so needs to be administered in an infusion center every 4 weeks and often may take longer than a typical subcutaneous injection. Benralizumab is administered every 8 weeks and can be used subcutaneously. And again, a self-injectable option is available. And similarly for dupilumab, while it's every 2 weeks, a self-injectable option is available. Going back to benralizumab, it's every 8 weeks, only after the first 3 doses have to be administered every 4 weeks. And then following that, it's every 8 weeks. So when I sit down and have a conversation with my patient about what next, or when I'm starting to have a conversation about their symptoms not adequately being controlled or that they're continuing to have exacerbations, and having the shared decision-making visit with the patient about initiation of a biologic next, there are many questions that patients ask me. Will the shot work right away? And the answer to that is typically, studies have shown that it takes 3 to 4 doses to really achieve optimal control, although biochemically, eosinophils may be decreased quite soon after the first shot in some cases. But in pragmatically, we often wait to assess efficacy or reassess efficacy at about 6 months. How will you know if the shot is going to work? Well, I often tell them that we monitor various things. We monitor how they're doing, their symptoms. We monitor if they're having exacerbations. We check eosinophils to ensure that they're low, especially if the patient is on an anti-IL-5 therapy. And we also look at their pulmonary function test, particularly their FEV1. Patients ask, what if the drug does not work? And that happens. We often reassess after a 6-month trial, and if the patient really has not had any benefit in terms of symptoms or cutting down exacerbations, we stop the drug. And it may be possible to consider another drug after some sort of a washout period, which is really not solidified in guidelines, but we could consider switching to an alternative is basically what I tell the patients. Patients ask, when can I start taking injections at home? Is it right as we start the drug, or is it down the road? This is mainly for injections that are available for home administrations. There are no clear guidelines. I can highlight what we do in clinic. We've elected to typically start the patients in clinic for the first 3 to 6 months before transitioning them to self-injections. for those that are available for self-administration, of course. This allows us to gain confidence that the patient is not having side effects to it or a lot of local reaction. It also allows some time for us to ensure that they're appropriately educated about how to administer these drugs at home. And plus, we reassess at about 4 to 6 months to see if the patient has had some improvement in their clinical condition and whether we would continue their medications long term. Should I continue to take my inhalers after the shot starts? And the answer is really yes. Having said that, if on chronic prednisone, I often tell patients to consider, come up with a plan after a few doses of the biologic to consider slowly tapering off. But certainly it's important to tell the patients not to abruptly discontinue steroids. Certainly there's risk for adrenal insufficiency, but also a risk that they may trigger an asthma exacerbation. But really it's important to work with their physician on coming up with an appropriate taper. So certainly some of my patients say that they're scared of needles, and we've all probably encountered such patients before. And studies show that about 20 to 30% of adults between the age of 20 and 40 are really scared or fearful of needles. Fear decreases as age increases, and needle fear and this phobia tends to be more prevalent in women compared to men. There are many patient barriers that have been identified to biologics, and I'd like to highlight some of these barriers, but also propose some of the solutions. Patients, particularly who live far and away, and they must come to the clinic for administration of drugs, I think that's certainly a very valid concern that certain patients have. The time that they have to perhaps take away from work or school, as well as the scheduling requirements. And so these are, to get through some of these barriers, it's important to know that some of these drugs are available for home administration or self-administration. Also, patient assistance programs are available. Cost is certainly a very valid barrier, and whether the drug is going to be covered by my insurance is a very common question that patients ask me, and that's really true. And we'll talk about prior authorization in a bit. Number of injections and the mode of administration. Again, this is where discussion in a shared decision-making model about what's important, subcutaneous versus IV, whether every 2 weeks is important or every 4 weeks or every 8 weeks, as may be the case with benralizumab after the first few doses. And so it's really this discussion about understanding what patient can do and is willing to do and really meeting them to meet that expectation. So there are certainly clinician barriers to the use of biologics. I'd like to propose some solutions here for those. I think prior authorizations with the insurance company is certainly a big and a valid one. And there are navigators available and assistance programs available for this. However, I'd like to leave you at the end of this presentation with some tips about how to get through those barriers. There's certainly lack of personnel, capital, or storage, and we'll talk a little bit more about what that means and how you can utilize brown bagging or white bagging to your benefit, or your patient's benefit, really. Time to testing and counseling patients, as well as the lack of knowledge of guidelines and of side effects. Well, you all have taken the first step by attending this lecture today, as well as all of our echo asthma sessions, to improve upon your knowledge on severe asthma and the options that are available for your patients. So I think hopefully some of the tips that we provide will help you get through some of these barriers. There are various types of drug procurement methods for the biologics. I'd like to highlight a few. The buy and bill method, where the clinician purchases, stocks, and administers medications, and then bills under the patient's medical benefits. This, as you can imagine, can be a bit risky for the clinician who would bear the upfront cost of the drug, as well as has to maintain an inventory. White bagging means that the drug is shipped by the specialty pharmacy to the clinician's office for administration for a particular patient, and then is billed by the pharmacy to the payer. So what the clinician's responsibility is to basically store the drug until it's administered to the patient. Brown bagging would mean that the patients acquire their own medications through the pharmacy benefit, and then actually walk it over to the clinician to administer. Clinicians certainly have lesser risk in this. You don't have to store or manage an inventory, and maybe less costly to patients. But patients will need to know how to store and handle the medication correctly, especially for the transport. Both white and brown bagging have really significantly increased over many years for omalizumab, which, as you may remember, was the first drug in the biologic market to be approved back in the early 2000s. So more tips on prior authorization. Certainly prior authorization or the need for it has been shown to lead to delays. In one study, there's a mean delay of about 43 days in the first dose, and about 42% of these patients required prednisone while waiting for an approval. So not only was there a delay for initiation of the drug, these patients actually had an exacerbations while waiting to start the drug. And so it's really important that establishing a protocol for documentation when you see your patient, have that shared decision-making visit, can avoid the delays, prevent denials and going back and forth, and really efficiently use your time and minimize how much time you would need. So some of the things that's really important to document in your note is, what the asthma control is, how are they doing, and that despite appropriately taking their inhaled corticosteroid and their other anti-inflammatory agents, that they're still getting into trouble with frequent symptoms. It's important to highlight their exacerbations history. So how many exacerbations have they had in the prior 12 months that have required prednisone or steroids, that have required potentially ER visits or urgent care visits or hospitalization. So really getting into that detailed exacerbation history, and then really documenting what the biomarkers are. What is that IgE level? What is that blood eosinophil level? And understanding and documenting that correctly would really go a long way for an efficient prior authorization process. That's really what the insurance company is asking. The one caveat I'd like to mention is for patients whose eosinophil levels are particularly checked when they are on prednisone, prednisone may actually mask the eosinophil levels. And so you may particularly want to document for that patient that the patient actually has prednisone-dependent asthma, or that we've been unable to wean the patient off prednisone. And so it's important to consider that the eosinophils may be falsely low in these patients, but that prednisone actually benefits their asthma. There are various resources that are available for help. You can check the websites for many of these drugs that have help for navigator assistance and things like that. So despite all of this, why am I telling you all of this? Biologics are really underused. They're good drugs, but they really overall remain quite uncommonly used for patients in severe asthma. Again, to highlight, this is step 5 treatment. This is add-on treatment for patients who are not controlled otherwise with inhaled corticosteroids or anti-inflammatory therapy in asthma. So it's for a small subset of patients. Having said that, even for that subset of patients, it's quite underutilized, as you can see in this study done in 2019. Thank you for listening, and we'll open this up for some question and answers.
All right. Thank you, everyone. Thank you, Dr. Kher. Mandeep and our hub team, what are our key takeaways from this lecture?
To complement some of the issues that Dr. Kher brought up last week, we can actually bring into this week as well too. And that is to talk about the 4 available options for children. The 5th, reslizumab, we're not going to talk about because that's only approved for those 18 years and older. But of our options, we have omalizumab, which can be given every 2 weeks or every 4 weeks, and now is available as a self-injectable. So it can be given in the home setting. So a little bit of an update from that lecture. And then you also have Nucala benralizumab, which notably can be given every 8 weeks, which is very beneficial for a lot of families that may have a little bit more difficulty adhering to every 2 week or an every 4 week regimen. And she mentioned the EpiPen as a mandatory part of giving omalizumab. For me, I like to give an EpiPen for all forms of biologic, especially if it's going to be given in the home setting too. The risk for anaphylaxis is not excessively high. It's not high with omalizumab. It's still a rare outcome, but still there is a potential for hypersensitivity reactions with the other agents. So that's why I like to give an EpiPen. The other thing too that's really notable is how long to wait for a response. So typically we want to wait at least 6 months for a response. And it's usually at that 6-month point that I tell parents, now we're going to talk about weaning. If we can get good control for 6 months, Now we can finally get you start weaning from some of these high dose or multiple forms of regimens that we had been on. The other thing too that I thought was really remarkable too was when how we document how it works, because a lot of them are provider oriented in terms of exacerbation rates and eosinophils and lung function. But for me, one of the most important factors is patients and their parents feel like they're getting better. If that's the case, then we know we're going in the right direction, more importantly. So that is one of the bigger things that I wanted to talk about, was that patient approach. And the other thing too, and you could provide some insight, after this as well too, is the lack of maybe switching biologics that are not working. There is some data out there to show that we've been keeping patients longer on biologics that might not be as optimal, and that maybe we are underutilizing the possibilities of switching biologics if they don't get good control with one biologic. The needle ferret thing option, she was talking a lot about that in terms of the adults, of course. But if you can imagine, she was saying that, decreases over time. Now we can imagine what that's like for kids, especially a caregiver who has to give an injection to their own kid. Now, we're used to that in pediatrics, especially those taking care of, populations that get regular injections. But it does take a lot of desensitization. Over time, most parents get it, but it does take a lot of time and effort and hand holding to overcome that. And then the other thing I just wanted to touch on, just two quick points. One about getting labs for the asthma. When we're getting the clinic note for the prior authorization, when we're getting labs, I generally like to get labs off of steroids because, like she mentioned, steroids can reduce the eosinophil count and therefore perhaps nullifying a biologic that could have been a potential option. We don't have in the pediatric population that many patients on chronic daily steroids or every other day steroids. So we usually have the option of getting a blood count when they're off of systemic steroids. So that's generally my preferred time to get it. But if they're always hospitalized and they never come in, at least we can get some other labs that are important to get in terms of getting their asthma phenotype. And then the final thing is that insulin article. It is a very, very good article. It's a very notable one. The references were listed in the bottom of the slide. But the two things that I thought were really important was that you were going to see it mostly prescribed in middle-aged populations, yet we know that asthma severity is still quite high in children. It could range from anywhere from 5 to 10%. It's probably closer to the 4% range, but that's quite high if you think about it at a population-based level. So maybe we're probably are underutilizing it in the pediatric population. The other thing too is that it's more likely to be prescribed for those with higher incomes as well as access to a specialist. So these are all really challenging issues that we as a community and especially the participants on this meeting have to be able to overcome it.
Thank you, Dr. Jassal.
I was just going to highlight some of the issues regarding that prior authorization issue because, my gosh, think about the cases we've had during this camp and how complex they are and how many times we're going to the ER and how much there's difficulties from social determinants of health. And you're going to tell me you're going to take 6 weeks to approve a medicine and 42% of the time I'm going to have to prescribe steroids again? Like, this is the reason they have expedited reviews. We don't really check that box as much as we should in family practice. But the fact that we're having these kids decompensate while they, think about whether they're going to give the right medicine or not is just infuriates me. Like, I want to just shave my head because I'm going to have to pull it out again. Like, it's ridiculous that they have to wait that long for these kids that are absolutely suffering. So, it's something that you want to try and get all your ducks in a row, get all your stuff together as far as what you're going to need for that prior auth standpoint. Kind of coach the family that this is going to be something that's going to take a while to get, but we're going to fight because this is what you need, and this is how I can try and keep you out of the ER and get your quality of life better. So it just fires me up.
Hey, Herm, don't sugarcoat it. Tell us how you really feel. Yeah, I had some thoughts as well, and I had my middle-aged son, who's let's say 26 now. Way back in the early 2000s, he was on Zolair. And lucky for us, he had been hospitalized 7 times. And so we were able to get it quickly approved. But one thing that was really important when Dr. Kerr talked about making sure that you're reassessing at that 6-month mark. And then she also mentioned how, it's not really a magic bullet. It's not going to work right away. And I know that my son had a hospitalization about 4 months into his care. And so just realizing that that can happen, and it doesn't mean that one of the biologics isn't working. It does take a little while. And then Mandeep, when you were talking to the parents and the patients about if they're getting better, and a lot of times for me, they can't seem to quantify that. And I'll say, well, let me rephrase it. So do you feel like you're using your albuterol inhaler as often? Did you use it as much as you did last week or the week before? And they'll go, oh, no. So, I mean, it's not really like they're feeling better. You have a headache and you take Advil and you start to feel better. But with asthma, it can be really tricky for people to understand the control levels. So I thought that was really important, having them look at, are you using your albuterol less? Are you doing less nebulizer treatments? And then they'll start to kind of click in with that. And then about not going off controller medication. I know some of these people, and my son was one of those, he couldn't go off any of his daily controllers, any of his treatment plan. That stayed. And then he was on it for 7 years. He was on injections for 7 years. And Mandeep, I also like your comment about checking to see about switching biologics. I have a colleague that has really terrible lung function, and she was on one biologic and wasn't really doing well. And so they switched her to another one. And she came into my office and she said, "You're not going to believe this." She said, "I'm finally up to 60% lung capacity." And that's how bad she'd been before. And so on this new biologic, she was trying to get better, and we're hoping that that will get better over time. But it's really hard on this to get the right person on the right biologic. And yes, switching is perfectly okay. And also wanted to talk about copay assistance. That's something that we used and we were able to get for 7 years. And so I think our copay was about $150 a month out of pocket. And then we had copay assistance, and we found a foundation and they paid our copays for 7 years. So I know it changes. It's based on income, all of the other things. And I know that it does take some time. We would have to reapply every year, but it's worth it to be able to get help, because on top of your biologic, then you're paying for your controller inhalers, and you're paying for albuterol, and you're paying for allergy shots. And, it really stacks up. So anyway, lots of good things out there available for people.
Hey, Andrea, to your point about whether the patient understands whether it's getting better or not, that's when some of those objective measures, like the asthma control test, can give kind of a better idea of, oh yeah, I guess I am better. So that might be an option for you too.
Yes.
I just wanted to add, thank you very much. This was a very good review. What we're finding in our area too is that the payers are now giving us like 6-month approvals, not a year approval. So we're having to reapply for another prior authorization in 6 months. So I'm really trying to coach all of the providers who have these high-risk patients to have kind of standardized formats for their notes that they can, thank goodness with EMR, that's something you can carry forward. And we carry forward the history of the hospitalizations, the labs, we update them at each visit. We do the reassessments with the asthma control test, spirometry if possible, and all of that, because at any point, at 6 months, I'm going to need, medical documentation along with my prior authorization and my letter of medical necessity and my blood to be able to get them pre-approved. And it's going to cause now a lapse in the middle of treatment. So you have, again, now weeks where they're going to tell you, and I always click expedited review. I always follow it up with a phone call, but they're still, they're still lapsing, and you're on pins and needles waiting for their response. So having the education out there for the providers that, these reassessments are not only so valuable just to be, reassessing your patient at the time, but also to support the treatment plans that we're trying to, give them and offer them. Yeah, six months now. It's just, I don't know if you're experiencing that, but we've now been experiencing that. So it's a little frustrating.
I have not experienced that, but I wonder if there's someone from that insurance company you can have a conversation with, because quite honestly, it's disrespectful to make you do all that much work.
Exactly.
You don't even know when you're gonna, you're not going to have
Exactly.
a full effect by then. I mean, it's like antidepressants for a month and expecting that to work.
That's what we said. We're just at the point where we're assessing and reevaluating it, and you're going to put us on the hinge of whether or not we're going to continue it. By in our area, it's one of our Medicaid managed cares. So unfortunately, you know, when you have one, the rest of them follow. And yeah, you know, it's frustrating. So
Yeah, Lisa, I've been experiencing the same thing, and it's a public insurance program that you're referring
right,
to.
exactly.
And me too. So every 6 months now, and most of our patients who have severe asthma are on public forms of insurance. So
Right.
I usually get a warning at the 5th month time period, or the 11th month time period, with a warning that I need to get everything aligned ahead of time. And although I have people to help me out, I'm lucky like that, but still, that still is a lot of paperwork and
Right.
an additional visit that the patient and the caregiver has to
Right.
have to undertake to see me too. So all of it is, you're 100% correct. This is really a very challenging issue. And then to respond to your one question about how long do
Yes.
you wait off of systemic steroids to recheck the eosinophil count? So normally I ask for all my kids with severe asthma to see me back in clinic 2 weeks after admission. Sometimes that's not possible.
That's what we do.
But yeah, so it's at that 2 week time point that I get the CBC with a diff and do my other asthma phenotype labs. Can it be done earlier? Sure, probably, because the pharmacokinetics of the systemic steroids are going to talk about, are going to probably result in a week or so.
Right.
Such a lower level that the eosinophil counts will come back up. But I would prefer the highest possible level to give me the best possible chance of getting all biologics on the table.
Yeah, thank you. I agree. We tend not to do that while they're in the hospital on systemic steroids. Yeah.
Thank you, everyone. Thank you, Lisa.
Sure.
All right. Let's see. Dr. Jassal, do you have any other pointed questions for the group, or do you want to get started on the patient case?
Well, I think I'd like to ask one question. It's really a follow-up to Herm's point, and that is on the control questionnaires or other patient-directed questionnaires. Is there any preferred patient-reported or patient or centered questionnaires to explore asthma outcomes that the group uses to talk about or to explore the severity of kids' asthma?
So one thing I use, there's some quality of life questions from EPR3, and that's what we use as I start a visit with each of my patients, because I want to figure out what's really affecting them. And I can send that to you, Ashley. It's just from EPR3. I don't remember which page it's on, but things such as what are you expecting from your asthma treatment? Are there things that you would like to do that you can't do because of your asthma? So are they ending up sitting on the bench? Can they not run on the track team? Can they not take the dog for a walk? So we get to some of those quality of life questions, and I think that's really important. So I'm happy to share that.
Yeah, I think those quality of life questions go into that shared decision-making process and kind of get a better idea of how that patient is responding to therapy. I have not seen those quality of life scores alter a prior authorization, unfortunately. So take that as you will.
Dr. Nietzsche, were you going to say something?
Yeah, we have the ACT test, but I think I prefer anamnesis. I know it's not as good as if you have always the same test, but I think you can get also some different forms of feedbacks if you have also informal questions. So at the time, that's what I prefer most, but always every 6 months we want to do a test too, to have something for the insurance, something official.
Yeah, Dr. Nietzsche, I totally agree with you. Sometimes spontaneity in the conversation does provide really good information as well too, that sometimes the questionnaires don't appreciate, because often questionnaires are so academically derived and were studied in such a rigorous way that we try to capture patients' input when we do these questionnaires. There's some difficulties with acquiring it. There are newer surveys being developed, like very recent, that or relatively recent, that are pretty decent in terms of capturing both symptom and quality. One of them is on the PROMIS measures. So it's PROMIS and without the E. And those PROMIS measures have a caregiver version as well as a patient one. And it's about the asthma impact. I think it's called the pediatric asthma impact score through PROMIS. And those are pretty good at capturing the symptom and the quality of life in one tool from both the patient's perspective as well as the caregiver's perspective. And it has a long form and it has a short form. And for me, who only has a couple minutes per patient, it's pretty nice to have that. Now, I don't know how it works Germany in terms of the equivalent for you, but it seems like it's a pretty decent tool.
It's called Promise?
Yeah, it's PROMIS. And they're the PROMIS measures. There's serial measures that we're trying to develop, these patient-reported outcome measures that we're trying to develop on a national level, so we can talk the same language about multiple disease processes. And they're pretty good tools. And I think one is called the Pediatric Asthma Impact Score, and the other is the Caregiver Proxy Pediatric Impact Score. And it comes in the long form and then the short form. The acronym is SF for short form. It's 8 questions, I think it is 7, 8 questions. Those I think are very good, very good. And there's even on the adult or adolescent spectrum too, there's some even newer quality of life measures that maybe have not been studied as rigorously in terms of, clinical trials, but the RAND Corporation in California also has some newer quality of life measures. They're actually trying to pull more of asthma control out of quality of life. In other words, get a pure measure of quality of life, which I think is a very important thing, because sometimes, and understandably, people confuse symptoms with quality of life, which do go together, but sometimes they need to be extracted a little bit more.
Yeah, true.
And I just want to say thank you to Lisa for adding in patient provider tools that she had mentioned in one of the other sessions. They were developed as we needed more virtual tools when teaching via telehealth. So we've got that link there and we'll add it into our resources. Thank you so much, Lisa. All right. Well, I think now is a great time for us to work on our final patient case. Okay, Dr. Jassal, whenever you're ready. We're having some trouble hearing you.
Sorry. This is an 8-year-old Hispanic male, born full term. No NICU requirements, no O2 requirements at birth. Unfortunately, we didn't have a strong childhood history for us to build upon, but we think that asthma developed around infancy, early toddler years. It's unknown if there was a viral trigger around that time period. The symptoms that he experiences is cough that's non-productive. It doesn't occur during sleep. There is expiratory wheezing, and along with shortness of breath. In terms of his responsiveness to beta-2 agonists, yes, it is responsive to 2 puffs of albuterol, but occasionally he does need up to 4 puffs of albuterol. And the family is uncertain if there's any benefit to albuterol prior to activities. And yes, it does seem to be responsive to steroid-based therapy. His typical triggers are viral-like syndromes. He has quite a bit of environmental allergens. No food allergies are reported. And exercise seems to be a trigger. So his current medication regimen that was started 8 months ago was Xolair at an every 2-week interval. It also included Symbicort, low dose, or lower dose, 2 puffs twice a day. And it also included Spiriva, 2 puffs once a day. He was on Singular as well, so a pretty extensive regimen. And then he had Symbicort as needed, which was using the SMART regimen as well. So that regimen of Spiriva, Singular, and Symbicort was all undertaken prior to the initiation of Xolair. And then in the past, he'd been on high-dose Flovent and Advair. There has been some concerns for medication adherence. Specifically, it exists because of the bi-monthly biologic administration that every 2-week interval is becoming very challenging for the family. And then as far as how many hospitalizations the patients required, he's needed 3 over his lifetime. Yes, there was some ICU requirements that did require high flow nasal cannula. He did not tolerate the BiPAP device at the time, so high flow was considered an alternative. He's had 3 ED visits, including 2 since the initiation of Xolair. His asthma control score has still been very poor. And I didn't mention he had 4 systemic steroid courses, 2 since the start of Xolair. His last asthma control test 6 months after Xolair is still quite poor at 9, and prior to the initiation of Xolair, it's 6. So significant, yes, but nothing terrific. In terms of environmental exposure, there's tremendous amounts of exposures that are ongoing, even during the Xolair time period. One is secondhand smoke exposures, the visitors who come to visit. Obviously, there's the lingering third-hand smoke exposures, and yes, pets. There is a dog present in another caregiver's home, so he has 2 providers, one on weekends and one in the weekdays. No other significant review of systems. He does have a very strong family history of asthma, no other significant family history. Review of systems is negative. I talked about his allergy symptoms, largely from an environmental standpoint, no food allergies. He did have an EKG done at his last ICU admission. It was unremarkable. No history or no concern for GERD. And has a history of rhinitis. It's treated with Flonase, has mild eczema. And from a hematologic standpoint, his last CBC was started before the start of Xolair, but no other concerning components of that blood count, and no psychiatric history. And I mentioned the Allegra and Flonase for the concerns for allergies and rhinitis. So prior to the initiation of Xolair, he has an absolute eosinophil count of 0.68 or 680 absolute eosinophils. And his total IgE was quite elevated at 1,068, no aspergillus antibodies. His vitamin D level looked okay, and we documented his environmental allergens as well too, some of the environmental allergens. And then in terms of the further diagnostic studies, his PFTs prior to Xolair showed a moderate obstructive ventilatory defect. 3 months after starting Xolair, it had a mild obstructive ventilatory defect, but it was still reversible with a bronchodilator. And now we got to the time point of post-COVID concerns. So this was 6 months after therapy where we couldn't rely on PFTs. So we had to rely largely on what we knew before us in terms of the steroid usage, the emergency room presentations, as well as the patient-reported outcomes. And the chest X-ray prior to all of this didn't show any underlying abnormality. And then his physical exam, when we saw him last, had some mild wheezing, even in the office. It was heard diffusely. His stats were fine. His weight and height were not unconcerning. So now we are past 6 months on therapy. And the questions that I had was, would you maintain, would you discontinue, or would you trial a different biologic other than Xolair? Would you do any other further diagnostic workup? Would you make any other changes in his asthma controller regimen? And I'll add a third one too. Is there any other factors in terms, or is there any other approach that we could take in terms of the potential environmental triggers that we, have been unsuccessful, in battling in terms of the smoke exposures, in terms of the pet exposures in different homes?
Thank you, Dr. Jassal.
Well, this is around the time I remind people there's no allergens to goldfish. But I wanted to ask Dr. Jassal or Andrea what you're doing with PFTs now as COVID is kind of fluctuating. Ours in Lancaster, Pennsylvania is actually going down a little bit, thankfully. We're trying to come up with a workflow to potentially bring back spirometry if the staff member and the patient or patient's family is vaccinated. Now, I know that kids haven't been able to get it very much, and it's hopefully going to be indicated from 12 and up soon as far as Pfizer. But do you have any thoughts about how to proceed with spirometry in a declining COVID area?
So we're doing spirometry again, spirometry lung volumes, whole lung function.
Dr. Jassal, I'm not sure. Okay, would you mind restarting that response?
Sure. We're doing, sorry, is there something wrong on my end?
No, I can hear you.
Okay. We're doing lung function and all forms of lung function in the office right now. The way we're doing it is everyone who comes into our lab gets a pre-screen for COVID symptoms. If they screen positive on any one of those symptoms, then we ask the provider, do you absolutely need this test today? And if they say yes, then we do a rapid COVID screen that we can get back within about 30 minutes or so, even less. And then we will do the PFTs that day, but under a higher level of caution. But if they screen negative, then we do the PFTs. We still keep a higher level of concern for this, like our staff still wear the face shield and our typical mask. Now, if there is a concern for some of our screen positive, we do have a higher degree of safety we're doing just for the safety of our staff. So what we're asking for those patients is to do them in a body box. So in a lung plethysmography machine. So as you can imagine, a lung plethysmography is a closed system. There's going to be an air leak, and we keep that air leak, that's part of the system because internal pressures have to equal ambient pressures. But what we do is, because it's just a small air leak, we do have a HEPA filter right next to where the air leak will occur. After the test is done, we look to see if the patient is coughing or not coughing, or they look like they're in any distress, like they're about to cough. If so, we tell them, cough in the machine in the closed system. And then after that is done, the machine is opened, we take them back to their room or such. But these are in rare circumstances, and then we wipe it down with Sidex or a high cleaning solution for those situations. But we are holding off on usually doing testing in only the most extreme circumstances for those we're suspicious of. But normally, because usually we're trying to not do testing on those patients.
Thank you very much.
Sure.
So for me, I'm not doing PFTs. I'm normally doing virtual visits now, or when I'm in the home. I'm not able to do those. But one thing that I do, and I know everybody has their thoughts about this, is peak flow meters. And I know that they are effort dependent. But I really think that if they're trained properly, they're so effective. And when my kids were growing up, I could hear them. I would hear them in the other room, and every morning they'd have to yell out their peak flow. And I could hear it, 350, 350, 350. And then my son knew you can hear them. And then he'd say 275. I'm like, do it again. And I could even hear a change in my kid's voice. So then I'd relay that information to the doctor and let them know, okay, he's dropping again. But every morning and every night, I really am a believer in that. And I know, sometimes people say, oh, the kids can fake it so they don't have to go to school. Well, my kid would rather be at school with his buddies. He doesn't want to be in the house. So anyway, that's what we've been using.
And Herm, one other addition too, I know that my colleagues in the cystic fibrosis world too have been utilizing home spirometry as well too during this time period. So I don't know how much of that is going to continue, but it's a good marker if you have it available at home.
I was wondering that too. Same for our cystic fibrosis center with home spirometry, and I was wondering if we were going to start looking into that for that severe population, at least, to have something else to monitor them with, especially if we need some of those indicators for treatment plans and things. So no one's using that right now. Is that what I'm understanding?
No, I don't utilize home spirometry for a lot of my patients. We don't have
Okay.
those kinds of resources
Right,
for my patient population. It's obviously very different than the CF group.
right, us too.
But with that being said, one of the greater challenges is finding good biomarkers of disease
Mhm.
for severe asthma. We still rely on, I'm not feeling well, and now we're going to act on it. So, we're still, we're still a little bit, sticking to the old ways for that. I'm not sure as a clinician, and I'll defer to the group too to see what they think. How much what fall of your lung function would you act upon? Would it be a 5% fall in your FEV1? Would it be a 12% fall? Like what fall would make you make
Right.
significant intervention? I think these are good research topics to explore because you don't want to overprescribe steroids based on perhaps poor effort.
For your patient, so many little bubbles came up, thinking for him. I'm sure everyone, the big red flags are definitely the environmental controls and what he's being exposed to on a regular basis and how much that's impacting his baseline inflammatory response, and his response to his therapy. And, are there any other programs that you can utilize for in-home assessments, education, community health workers, home care nurses, any remediation programs, anything to be able to continue to educate them? I did share my asthma trigger house if you want to play that game with them. That might teach them a little bit more, and it goes over all of his triggers. But I do think that's a big red flag. Part of me was thinking, oh, maybe he would be a candidate for immunotherapy, but if he's having a hard time coming every 2 weeks for Zolair, immunotherapy is not going to be something for them. You would think, changing his biologic is possible. He could, he's got he's got a mixed allergic picture, so you could try one of the other biologics for him, and something that isn't so frequent might be better for them. But I'm just feeling as though the child is in a situation of a psychosocial kind of drama, and he's circling the drain with all the issues that are going on there. And until those kind of can get addressed, he's kind of stuck. So sounds like a little bit like my patient that I presented. Also, it's those situations that are so difficult, kind of chipping away at them. But I don't know what programs you have locally in your area, but I try to utilize as many of those as possible.
Well, we have some options, but unfortunately it was the time of COVID, so we had only limited home options, like in-home options. So we did have, because the Baltimore City Health Department, where I am affiliated, well, that would be my affiliated health department. A lot of it had pivoted towards COVID, understandably so. But things are changed recently. But I don't know if Andrea has any thoughts on some of the home care options.
Yes, and I know Green and Healthy Homes is available in some states, and Dr. Jassal, I know that you have that, and I don't know if they're starting to do in-person visits. We're starting to open up a little bit here. Our rates have dropped significantly for COVID. So for those of you not familiar with Green and Healthy Homes, they really have a whole home-based approach. So they look for lead, they look for asthma triggers, they check on air quality. There's a lot of different things that they do, and they can remove carpeting, and they can install solid surface flooring and things like that. They can provide a HEPA vacuum. They can provide furnace filters, different things like that. So one thing with this little guy, I know he's got the 2 homes, and so I'm thinking, the dog, people aren't going to get rid of their pets. It's like an animal, and I know it's like fingernails on a chalkboard for you, but it's like a family member, and I get that they're not going to get rid of the pet, but could we have one safe room in the apartment or condo or wherever he lives for him? And if he could have, I really would start with having him change the furnace filter if they're allowed to do that. I don't know if they're renting or owning, but if they could have a MERV 13 or above, if their furnace will pull that. A lot of furnaces won't, they're not strong enough. That's a great rating that will really trap those smaller particles. Also, if the little kiddo can shower before he goes to bed, get all the dander off, have some nice clean sheets. If he can have a standing air purifier in his room, I think that would help significantly, and keeping the dog out. And I understand that that's hard, but even if you want to snuggle the dog before he goes to bed, go in and shower and then climb into bed. I think those would be some great environmental options. And then, I think about back in the day when men used to wear smoking jackets. And they put that on and they go outside and smoke and they come back in. I've had asthma attacks from third hand smoke, and I don't think people realize how bad that is. So that's a different process of trying to help the family members that are smoking. And I know that it takes multiple attempts before someone can quit. And it is an addiction, and it's something they're going to fight. And so I don't know if, how to approach that. That's really difficult. They know it's unhealthy. They know they need to approach, or to quit, but to approach them and get them to the point of setting a quit date and working with the tobacco program. All of the state health departments have those and have all sorts of patches and other incentives that they can give. So just a couple ideas.
I try to empower the parents to be the kind of the air police. That's what I tell them, like, especially the dads like that. It gives them something that they feel they can do. And I always talk to them again. I know we've talked about this before. I talk to them first about something that they can relate it to, like if they've ever had a sunburn. And then we talked about, like, what would make your sunburn worse, and would you ever let me do those things to you? I'll still put the aloe cream on, but would you let me make you sit in the sun with a sunburn? Would you let me put hot water on you? And they say no. And then I say, okay, now your child's airways are like as if he has a sunburn in his airways. They're very irritated. They're very raw, and they react very quickly to irritants. So let's start looking at some of those irritants. And like Andrea said, I don't go to the dog right away because I know we're going to have an emotional response. I don't go to their smoking right away because we're going to have an emotional response. So I might talk about the cleaning fluids that maybe they have some choices over, or, that whatever keeping the windows closed or something like that during pollen. And then we'll slowly get to that. I'll talk about candles and incense instead of going right to their cigarettes. We'll use the asthma trigger house, and we'll go room by room, and we'll talk about each one of the things that they find. And it's a game, and it's a fun game to play, but at the same time, it's interactive, and the parents are learning along with us. And then we talk about, okay, this is what that's suggesting. What of those things can you do? And then I truly just say to the father, okay, if I had a badge, I'd give it to you now. You're your child's air police in the home. And you're the one in charge, and you're the one to tell everyone else about this. And you're the one to keep the dog out of the bedroom. You're the one to, and try to empower them a little bit more instead of them feeling as though they're embarrassed or afraid to talk to us. Because once we build that barrier with them, you're not going to get anywhere. So I find that, trying to empower in a split home, it's even, a little harder. But, I tell them that the child is really at the mercy of what we give them for air to breathe. And let's at least start in the bedroom, one small space in both houses that we can look at and say, what can we do in this small space? Once you have that, you look at the next room where the child spends the most time, and you keep going. And if we start chipping away small, maybe we'll make some headway. And again, if you have programs like Green and Healthy Homes, that's fabulous that they could, help you with things like that. But I try to keep out of the defense mode with, get them in that defense mode, because you've lost everything if that happens.
Thank you so much, Lisa. All right. So Dr. Jassal, do you want to give us just a quick summary?
So this is I think it was 8 or 9 at the time of when we saw him with severe asthma on a multi-drug controller regimen, which included our prescribed Xolair every 2 weeks. He was not compliant with the regimen. And then by the time the pandemic was ongoing, we lost contact with him. And I recently re-engaged contact with the kid through a communication with a provider at our neighboring hospital center across the way in Baltimore. He'd been admitted over there with a pretty severe exacerbation. And so he has been off of Xolair since the time period of our last clinic visit. I didn't re-prescribe it, mainly because he wasn't taking it. And there had been poor follow-up. We knew that at the time. Because of the recent admission, we are working with our social workers and our health department to see if we can get them back onto a good, hopefully reasonable controller regimen, and they're trying to locate housing outside of this where they currently live.
Thank you, Dr. Jassal. All right, well, it's about that time. We have our post-test, our final post-test polling questions for everyone. Question 1. Which of the following is not available for subcutaneous injection in the United States? Benralizumab, mepolizumab, omalizumab, dupilumab, or raclizumab? Question 2. White bagging is a method of medication procurement in which the pharmacy delivers the medication directly to the patient who brings it into the office for administration. True or false? And 3. According to the study by Enselman and colleagues, which factor is not associated with the use of biologics for severe asthma? Middle age, higher income, access to a specialist, or Medicare or other government-sponsored insurance? All right, thank you everyone for answering those. I'm going to share. Okay, Dr. Jassal, how'd we do?
Very good. Which of the following is not available for subcutaneous injection? That's correct. Raclizumab, it's only IV. White bagging, true. The answer is false. Yes, it is more common. The way it's described as white bagging is where the physician gets the medication, and then the physician will be responsible for administering the medication. So the correct answer is false. And then according to the study by Enselman, which factor is not associated with biologic usage for severe asthma? The correct answer is Medicare or other government-sponsored insurance. The first 3 are linked with more likely to have biologic usage.
Excellent. Thank you, everyone. Thank you, Dr. Jassal. And of course, this is our last session for your boot camp. So I just want to say thank you all so much for joining us. This has been a wonderful boot camp for all of us. Thank you all for your contributions. And as always, thank you to our wonderful hub team. One last echo clap for ourselves. Thanks, everyone. All righty. Hope to see you again. Please reach out if you need anything. Bye-bye.